Okay, good morning, everyone. I'd like to thank the organizing and scientific committee for the invitation. And I got nothing to disclose. I'll start with a case. This is a 77-year-old lady who's diabetic and known case of severe osteoporosis. Her T-score is minus 3.8. As you can see, there is a significant compression fracture at L4 with step ladder deformity at this segment. So as Dr. Sadat Ali mentioned, that osteoporosis is a major global health problem characterized by significant low bone mass with structural deterioration, which will lead to implant failure. As we know that the population is aging and in addition to those comorbidities. There is a study that showed that patients over the age of 50 undergoing spinal procedure, the prevalence was about 14% in male and up to 50% in females, which is pretty significant. In the United States, it affects more than 10 million adults, and the mortality and morbidity associated with osteoporosis can cost up to 17 billion a year. The challenges associated with osteoporosis is the porous damaged bone will dramatically affect the load sharing across the vertebral body, which contributes to implant failure. So what are the strategies that we can use to improve or minimize complications? So there are basic surgical techniques, which includes increasing the screw diameter or length, starting a small pilot hole, using a longer construct, which means longer levels or more levels, under tapping the track. Personally, I never tap any pedicle. Supplemental anterior fixation, or using hooks or sublaminar bands or marceline tape. There are novel surgical techniques described especially for osteoporotic patients, using cortical bone trajectory, using double screws in the pedicle, using a cross screw trajectory, which is putting a pedicle and a cortical screw at the same time, using expandable screws, fenestrated pedicle screws, conical screws rather than what do you call it? Hydroxyapatite coated screws and dual thread screws. So other strategies are most commonly used, using cement augmentation of pedicle screws, doing prophylactic vertebroplasty at the UIV and UIV plus one, using hydroxyapatite granules, and very important aspect, as Dr. Sadat Ali mentioned, is the perioperative optimization using medications. So in terms of pedicle screw design, conical screws allows for greater purchase across the pedicle. And the V-shaped threads has the best pull-out strength across the pedicles. Dual thread screws are recently designed, which is going to increase the pull-out strength by 20%. Bicortical screws improves the pull-out strength up to 120%. Hydroxyapatite pedicle screws will increase the biomechanical properties of the construct, and it will increase the pull-out strength by 1.5% compared to the conventional screws. Expandable screws, I've never seen one or used one, but these screws allows for compression of the cancellous bone within the vertebral body that creates a better, higher bone density around that screw. You can see some side expanding blades and different shapes used in that technique. So what's the trend lately? If you look at the publications, there has been an increase in the described anchors, mainly using bone ingrowth or the hydroxyapatite screws in the last decade. What are the pros and cons of all these techniques that I just went through? Interestingly, I'm not going to go through the whole table, but the hydroxyapatite screws, one of the disadvantages is the difficulty in removal because of the bone ingrowth around that screw. So what about cement augmentation? I think this is the most commonly used strategy by most of the surgeons. Using cement will definitely create a superior environment which has a clinical and biomechanical advantage, which is clearly described in the literature. So basically what we do is inject the cement through the fenestrated pedicle screw. If you don't have an access to that, you can just do a vertebroplasty and then insert the screw after that directly. What does the cement do? It allows load distribution across the weak vertebrae to reduce the risk of screw failure, and the average injection is about 1 to 3 ml per screw. There are two types, either using polymethyl methacrylate or using calcium phosphate. PMMA is a low cost and it's the most commonly used, although calcium phosphate does have a weaker plot strength. Compared to PMMA, it has the advantage of being degradable in the body, and it does not cause any thermal necrosis as it works through endothermic reaction. Using cement augmentation will double up the pull-out strength for those conventional, pedicle screws. And this technique is associated with devastating complications sometimes, which is known as cement embolism. Cortical screws, it relies on maximizing the cortical-subcortical contact of the screws. Hooks and bands are well-described techniques. You can use sublaminar bands as shown in the illustration, and sublaminar hooks, which is the mostly dense bone, the vertebral body. Hydroxyapatite granules, I've seen few papers, nothing much in the literature, but the technique described is using funnels. You can cannulate the pedicle, do your tap, and then use the funnel to impact those HA granules, and then insert the pedicle screw after that. And this is a CT illustration showing the bone ingrowth around that pedicle screw. So back to the case. In this lady, luckily she did not have any neurological deficit, so what we did is doing a vertebroplasty at that level and using augmented screws. This is her 3 months post-op x-rays. That's another case, classic compression fracture with kyphosis, using cement augmented screws. Moving to different patient population, adult spinal deformity. This is a lady who underwent, this is not my case, underwent 2-level TLIF. At 18 months, you can see some retrolisthesis at that level, progression of her symptoms, and she developed PGK down the road, and which altered her sagittal balance. So another surgery was done elsewhere, and they extended the fusion by 3 levels and used soft landing at the upper levels. As you can see, intraoperatively, the screws were in the body. Just 3 days post-op, one of the screws just cut out the upper end plate. And then after 1 month, complete collapse and significant PGK at that level. So vertebrectomy was done at the apex of the deformity, and probably this was discussed earlier at the adult spinal deformity session. We used the soft landing at the upper part, and UIV and UIV plus 1 vertebroplasty. So in conclusion, osteoporotic spines represent a challenging biological environment to achieve a strong integration of spinal implants. There are numerous technologies, however, have been specifically designed to assist surgeons. These advancements include cement augmented screws, dual thread pedicle, and cortical screws. All of these implants have advantages and disadvantages. Surgeons taking care of those patient population should be comfortable with whatever they have in their hospital. Finally, perioperative optimization of those patients is crucial to prevent mechanical complications. Thank you very much.